So it's 6:35. So good evening, everyone. And it's my pleasure to welcome everyone to this live webinar. This webinar is being conducted under the auspices of the Global Antibiotic Resistance Partnership. This is a partnership between One Health Trust and Christian Medical College, Vellore, and various other members of standing who are part of various national technical advisory groups on immunization and who have extensive experience with dealing with AMR. I will now actually request all of the participants to put themselves on mute. Please do ask questions if required in the chat box, and we will have a moderating session at the end, which will be conducted by Dr. Rajiv Das Gupta. So it's my pleasure to invite each and every one of you. We have a wonderful speaker, Dr. Anuj Sharma, who's part of the WHO Country Office of India, and I will request Dr. Satinder Aneja to introduce him in a little bit. My pleasure to also introduce Dr. Rajiv Das Gupta, who will be formally introduced after the lecture is done by Dr. Prasanna Kumar. So thank you, everyone, for being here. And I will also welcome the members of the One Health Trust if they're online. We don't have a formal thing to introduce them, but if you are there, please do unmute and introduce yourself. Okay, so we're looking forward to Dr. Anuj speaking to us, and I will now hand over to Dr. Satinder Aneja. So it's my pleasure to introduce Dr. Satinder Aneja. I think I came across Dr. Aneja just last year. Dr. Aneja is a former professor and head of pediatrics from the Lady Hardinge Medical College. She's also the chairperson of the National Technical Advisory Group on Immunization. She's been widely involved in various guidelines, and most recently, she's been involved in the WHO meningitis guidelines as a guideline development member as well. Dr. Aneja, it's wonderful to have you here, and I request you now to introduce to the audience Dr. Anuj Sharma from the WHO Country Office, India.
So thank you, Priscilla. So it's a great pleasure to introduce Dr. Anuj Sharma, who has a distinguished career as a microbiologist. He is a graduate from Maulana Azad Medical College, and after that he did his post-graduation in Lady Hardinge Medical College and his senior residency. Subsequently, he has been working as a clinical microbiologist in Gangaram Hospital, where he spent along more than 13 years, rising to senior consultant. And I think he was also closely associated with all the microbiology newsletters in Gangaram Hospital. Has been closely associated with WHO in various fields related to microbiology, for example, hospital-associated infections, strengthening health laboratories in neighboring countries, lab information systems, and also antimicrobial resistance. So, and this also made him interested in public health issues. And currently he is working in WHO Country Office, strengthening the lab surveillance for diseases of public health importance. And he's also the technical and team focal point of AMR and IPC at WHO Country Office for India. So very important person for our webinar. So, and looking forward to hear from you, Dr. Anuj. Over to you now.
Thank you, Dr. Aneja, for the kind words. And thank you, Dr. Priscilla, for inviting me to speak on this topic. And at the outset, let me, unequivocally say that I'm not the expert in this subject that I'm talking on, and I'm standing on the shoulder of giants, the global experts on vaccines, global experts on antimicrobial resistance, as well as colleagues from WHO headquarters. So I will talk a little bit about the vaccines and antimicrobial resistance, and then I will focus primarily on the WHO report, which is actually titled Estimating the Impact of Vaccines in Reducing AMR and Antibiotic Use. And for this, I'd also like to thank Dr. Matthews from WHO headquarters, who's been kind enough to share his slides with me. But before I start, I would also like to, say that vaccines have saved more human lives than any other medical invention in history. Starting with the vaccine for smallpox back, the experiments of Edward Jenner, as well as the endorsement of the smallpox vaccine by early 1800s by the French Emperor Napoleon and the American president at that time, as well as Louis Pasteur's work. Influenza vaccine, which actually became a U.S. military priority during the Spanish flu pandemic, killing 1 in 67 soldiers in the country. So subsequently, WHO's intensified smallpox eradication program led to mass vaccinations and the MMR vaccine, as well as the Global Polio Eradication Initiative. This is just to give you, and in case anyone is interested, there's a history of vaccination available on the WHO website from which these facts have been taken. But all of us understand that antimicrobial resistance is a global priority. It's a global priority endorsed by the World Health Assemblies, as well as the UN General Assembly. And it needs a lot of people to work together for its containment, because AMR cuts across a number of sectors, but within the health sector, it impacts patients, hospitals, as well as has a global impact, leading to more than 5 million deaths every year. This is from the Lancet study published in 2019. It has an impact on the global GDP, extra healthcare costs, as well as the GDP losses every year, and it also has potential impacts on the pharmaceutical industry, the vaccine industry, as well as tourism and food exports. Now, if you look at the drivers of AMR, the two main drivers of AMR are antimicrobial misuse and overuse, both in humans and animals, as well as healthcare-associated infections, suboptimal dosing, environmental contamination, as well as suboptimal vaccination. But how do vaccines prevent AMR? I mean, vaccines protect individuals, reducing the chances of infections. They also prevent complications, leading to prevention of secondary bacterial infections necessitating the use of antibiotics, and also reduce transmission in communities. And this decrease in infections of both resistant and sensitive pathogens also leads to a reduction in antibiotic use, which also sort of suppresses the evolution of resistance, decreasing not only individual risk and the transmission of resistant pathogens, but also ensuring a longer shelf life of existing antibiotics. At the global level, vaccines are a part of the Global Action Plan on Antimicrobial Resistance, endorsed by the World Health Assembly in 2016. In the Pillar 5, focused on research and development and investments, vaccines are a key part of the entire preventive aspects of AMR. Also, WHO published this last year, the Global Priority Pathogens for Vaccines Research and Development. And across the 6 WHO regions, 5 pathogens were prioritized in all regions. And this included Mycobacterium tuberculosis, HIV, Klebsiella pneumoniae, Staph aureus, and extraintestinal pathogenic E. coli. But also, if you look at some of the other WHO guidance, WHO has been tracking the bacterial vaccines in clinical and preclinical development over the years, and also leveraging vaccines to reduce antibiotic use and prevent AMR. And the recent publication from October 2024, estimating the impact of vaccines in reducing antimicrobial resistance and antibiotic use. Subsequent slides focus primarily on this WHO report published in October 2024. And what this report actually summarizes is that vaccines have the potential to avert more than 500,000 deaths every year, 28 million DALYs, also reduce 30 billion, save 30 billion US dollars in hospital costs, as well as 20 billion US dollars in productivity losses, all associated with AMR, as well as save 2.5 billion antibiotic doses, defined daily doses of antibiotics. Now, this report actually works on WHO's previous work, which was published in 2021, the action framework to leverage vaccines against AMR and antimicrobial use, which is primarily an annex to the Immunization Agenda 2030, also the Global Vaccine Action Plan. And it has three key areas: expanding the use of licensed vaccines to maximize the impact on AMR, develop new vaccines that contribute to prevention and control of AMR, and expanding and sharing knowledge of vaccine impact on AMR. Now, also a desk review which looked at vaccines and national action plans on AMR found that a lot of countries have included vaccines in their national action plans, but however, it's not that all of them have included. Some of the national action plans do not even mention vaccines, and only one-third or only 33 out of the 67 NAPs have developed indicators to capture the role of vaccines against AMR. So there is some understanding on the role of vaccines in reducing AMR, but it's not translating into action and integration with other AMR interventions. And a major gap in a lot of national action plans on AMR is to what extent can vaccine reduce antimicrobial resistance? And this document actually, the methodology was looking at the role of vaccines in reducing AMR. It looked at three key things: the vaccine-averted AMR health burden, the vaccine-averted antibiotic use, and the vaccine-averted AMR economic burden. For the first thing, the vaccine-averted AMR health burden, 24 pathogens were identified based on the WHO priority pathogen list, the CDC AMR threat list, and the Indian priority pathogen list. And for these, along with these 24 pathogens, 44 vaccines and the attributes were selected. And these were pathogens with existing vaccines, also pathogens with vaccines in late clinical development, as well as pathogens with vaccines in early development. So this is not just the existing vaccines or vaccines which are in the pipeline, but also includes vaccines in early development. The methodology was, in addition to these 24 pathogens and the vaccines, the global burden of disease data on AMR was used as the backbone for the analysis to look at the impact of the vaccines in reducing the AMR burden in direct proportion to the vaccine efficacy and coverage. And this is a lot of modeling has been done to look at the burden averted at various age groups and the vaccine efficacy, as well as the vaccine coverage for these individual pathogens. Now, if you look at the potential impact of vaccines in averting deaths associated with AMR, overall 515,000 deaths associated with AMR annually. This is nearly 1/10 of the 4.95 million deaths estimated, which are associated with bacterial AMR every year, out of which the majority are in the African region and in the Southeast Asia region. Existing vaccines could avert more than 100,000 deaths every year. Vaccines in late clinical development could avert another 135,000 deaths associated with AMR. And the existing vaccines would be the strep pneumonia vaccine. And again, the numbers after these vaccines are the modeling estimates based on the vaccine coverage and the efficacy. And late clinical development is the example is the TB vaccine, and vaccines in early development could avert another 400,000 deaths every year. And for this, the example would be the Klebsiella pneumoniae vaccine. Again, the vaccine averted antibiotic use looked at the data on antimicrobial consumption from the GRAM study, as well as the data on community use through systematic literature reviews, as well as the data from the Global Point Prevalence Survey on antibiotic use in hospitals. And again, the attribution, triangulation, and this led to the results of the estimated vaccine impact on a reduction of defined daily doses of the antimicrobials in averting these antibiotic use. Also, when we look at the potential impact of vaccines on averting antibiotic use, potentially vaccines can avert up to 2.5 billion defined daily doses of antibiotics every year. And this is roughly 22% of the evaluated burden, roughly 40% in CRO, and this has the maximum impact in the Southeast Asia region. It's estimated, and existing vaccines could avert up to 142 million defined daily doses. Vaccines in late clinical development, like TB, 1.9 billion defined daily doses, and vaccines in early development, for example, the group A strep, could avert up to 500 plus million defined daily doses every year. Again, when you look at the methodology for looking at the vaccine averted AMR economic burden, it looked at systematic and desk reviews of data collected on the length of hospital stay, the cost of treatment, bed day, unit cost estimates, and employment and wage estimates. And these were converted to 2019 US dollars and adjusted for inflation, following which meta-analysis was done. And again, AMR unit cost repository was created for all drug pathogen combinations as per WHO region, with following which triangulation was done and the results were estimated. And the potential impact of vaccines on averting hospital costs associated with AMR was that vaccines have the potential to avert up to 30 billion US dollars in hospital costs. And the maximum impact was in the AMRO region, the Americas, North and South America, in treating resistant infections. Existing vaccines, for example, strep pneumonia, would avert up to 861 million in hospital costs. Vaccines in late clinical development, like TB, would avert up to 1.2 billion US dollars in hospital costs every year. And vaccines in early development, like the Staph aureus, could avert up to 30 billion US dollars in hospital costs every year. If we look at the regional impact of these vaccines in reducing AMR, and if we look at the first pie chart, which looks at vaccine-averted deaths associated with AMR, the maximum impact is in the Afro region, followed very closely by the Southeast Asia region. 33 and 32% of the global averted burden. This is something which is, has impact, has great significance for India as well, being in the Southeast Asia region. If you look at the vaccine-averted hospital costs associated with AMR, again, out here, the WHO AMRO region has the highest sort of impact with savings up to US $9 billion in hospital costs, nearly 30% of the global burden which can be averted through vaccines. If we're looking at the vaccine-averted antibiotic use, it has the maximum impact in the Southeast Asia region. 39% of the global burden can be averted. Again, this has implications for India as well, being in the Southeast Asia region. So Southeast Asia region will have huge impact in terms of the saving the doses of antibiotics as well as the vaccine-averted deaths associated with AMR. There are a number of additional resources which are part of this global report. Each of these vaccines and the modeling which talks about the target age group, the duration of the impact, the usage scenario, is it part of the WHO AMR priority pathogen list or not, and the feasibility of its development. Each vaccine is profiled in this, and this is available online on the Vaccine Impact Dashboard, which is publicly available on the WHO website. In addition, this also gives the impact of AMR by vaccine and region, looking at individual pathogens, the individual vaccine scenarios, and the burden and the impact of that vaccine, as well as the comparison of the vaccine impact on AMR in terms of the antibiotic use, hospital costs, productivity loss, bed days, DALYs, etc. There are a number of other additional resources which are available on the WHO website based on recommendations. These are brief snapshots, 3 pages each, for different target groups. There's a snapshot for policymakers with very clear-cut recommendations, a snapshot for funders, a snapshot for researchers working on newer vaccines, a snapshot for program implementers, as well as quick tips for community representatives, as well as for health workers. Now, just to summarize the key results from this report, the vaccines have the potential to annually avert more than 500,000 deaths every year, save $30 billion in hospital costs associated with AMR, and save 2.5 billion antibiotic-defined daily doses. And if we break it up, existing vaccines every year can save 106,000 deaths, 9.1 million DALYs, $861 million in hospital costs, all associated with AMR, and reduce antibiotic use by 142 million defined daily doses every year. Vaccines in late stage clinical development would avert 135,000 deaths, 5 million DALYs, save $1.2 billion in hospital costs, all associated with AMR, and reduce antibiotic use by 1.9 billion defined daily doses every year. Vaccines in early clinical development have the maximum impact and could save more than 400,000 deaths, 23 million DALYs, 30 billion in hospital costs, all associated with AMR, and reduce antibiotic use by 548 million defined daily doses every year. Having said this, there are a few limitations in the methodology that the findings are based on modeling analysis, not direct observations. There's a reliance on the Graham project estimates, which have limitations, especially in low and middle income countries. And of course, data on certain areas like TB associated with HIV, full morbidity outcomes. This data is not fully available. Also, there are data gaps in AMR impact. DALY is underreported for conditions like enteric pathogens, malaria-linked infections, and group A strep. And full morbidity outcomes could also significantly increase vaccine impact on AMR estimates. Again, this is a static model approach, focuses on direct vaccine effects. Indirect benefits like herd immunity are excluded. Standardized approach limits the pathogen-specific dynamics analysis. Also, the assumptions based on the coverage assumes, especially for the vaccines, an early development model assume moderate to high coverage, which is could be overestimation of their coverage. And also there are other factors like reduction in antimicrobial use on future AMR prevalence, also omits vaccine effects on non-target pathogens like the influenza vaccine indirectly reducing strep pneumonia infections. Scope of the analysis, again, is focused on routine vaccination impact and the missed potential impact of vaccination campaigns are missed. And also the estimated vaccine effects on antibiotic use are there, but not on antimicrobials or secondary infections, and does not address vaccines' impact on drug-susceptible pathogens, focusing primarily on AMR-specific effects. There are some research areas also which are gaps. How does a reduction in antibiotic use contribute to the overall changes in AMR prevalence in different healthcare and community settings? How do vaccines indirectly reduce AMR in non-targeted pathogens through bystander effects? What standardized methodologies and outcome measures should be adopted to evaluate the impact of vaccines on AMR? How can protocols for assessing vaccine impact on AMR be harmonized across different contexts and regions? What is the impact of vaccine introduction or scale up on AMR in low and middle income countries? What are the insights that can be gained from existing data sets, such as impact of malaria vaccines on antibiotic use in AMR? Also, research and development challenges for vaccines targeting pathogens with high AMR impacts, such as Klebsiella pneumoniae, extraintestinal pathogenic E. coli, Staph aureus, and non-serotype specific pneumococcal vaccines. What is the role of vaccines in reducing AMR in animals? And what is the impact of human AMR when considering the One Health approach? How can combination vaccines address multiple pathogens contributing to AMR? So these are some of the gaps which still remain and needs some more research. Now, the specific recommendations from this report is 7 recommendations in 4 areas. First is to introduce and increase the coverage. Monitor the resistance patterns of circulating pneumococcal and H. influenza B strains so that vaccine products and vaccine strategies can be adapted accordingly. Expand the existing surveillance networks, such as GLASS, to include typhoid, especially in Africa. India already monitors typhoid in the National AMR Surveillance Network. Also, third is to include the impact of vaccines on AMR and reduce antimicrobial prescribing in vaccine cost-effectiveness analyses. Also, prepare for introduction of vaccines and analyze existing data sets to understand the impact of malaria vaccines on the use of antimicrobials. Also, in terms of understanding the role of vaccines alongside other approaches to reduce AMR, new surveillance platforms and enhancement of existing platforms need to be sort of strengthened to collect burden data for pathogens where such data are lacking, especially in low and middle income countries, to aid the understanding the broader impact of these pathogens and the potential role of vaccines. Also, in terms of enabling vaccine development for vaccines in early to mid-clinical development with a high potential impact on AMR, especially in LMICs, there is a need to conduct analysis to identify minimum and optimum sets of attributes required for a vaccine to make an impact in target countries. For vaccines targeting high-risk groups that are diverse, poorly defined, or difficult to immunize, for example, the hospital patients conduct analysis to identify and ensure timely immunization of the mentioned populations. I would like to stop here and thank the organizers for providing an opportunity to share some of the work done by colleagues at WHO headquarters. And I'd like to especially acknowledge the inputs of Dr. Matthews, who's the technical officer in the IVD division at WHO headquarters, for sharing the slide set for this WHO report. And again, the key message, we need to work together to prevent AMR. Thank you.
Thank you, Dr. Anuj, sir, for this wonderful and insightful question that you have made today. That is one of the low-hanging fruit which can be quickly grabbed, and with a little investment, we can achieve a huge output. Thank you, sir. Now we'll move on to our question and answer session, which will be moderated by Dr. Rajiv Dasgupta. It's my pleasure to introduce Mr. Dr. Rajiv Dasgupta, who's the professor and earlier the chair for the Center of Social Medicine and Community Health from Jawaharlal Nehru University, New Delhi. And he's also a member of various board and technical group of the government health agencies, and currently is actively involved in teaching of MPH, MPhil, and PhD students of various courses ranging from epidemiology, communicable disease, and nutritional and maternal health and child health, community health and its organization in India, and administration and health. Over to you, sir, to moderate the session.
Thank you very much, Dr. Prasanna and Dr. Anuj, as always, a very succinct presentation. I'll read the questions that are there in the chat, and then would encourage participants to raise their hands. I myself have a few questions, but I'll reserve them to the end. So the first question, maybe you can see, Dr. Anuj, on the chat box from Dr. Arun Duggal. Any data reflecting the dropout rates of booster doses of vaccines and their impact on AMR? So booster doses and missing the booster doses and AMR. You're on mute.
Thank you, Dr. Arun. Excellent question, but again, I'm not aware of the data about this, and I would look forward to the members on this group, because the National Technical Advisory Group on Immunization, as well as the Global Technical Advisory Group on Vaccines and AMR, they are the experts who can probably answer this question. And I was surprised when Dr. Priscilla asked me to talk on this, because this is not my core area of expertise. but it's always a pleasure to interact with experts. So I said, okay, I will take the help of my colleagues at WHO headquarters and share some information on this topic with the experts. But as I said upfront, this is not my area of work. My area of work is primarily looking at AMR containment and infection prevention and control, with a primary focus on India, but of course being part of the WHO 3-level working groups, also collaborating with the WHO regional office and headquarters. But again, I will request any of the other experts. Yes, Dr. Priscilla has chipped in. I think she's already mentioned that most of the AMR burden in India is the gram-negative organisms. Oh, okay, that's the next question. But again, before we come over to the next question, any of the other clinical experts would like to chip in? The floor is open for them.
Yep. So I joined Dr. Anuj Sharma in appealing to the enthusiasts and the eminent members in this group. Dr. Sharma, while we wait, to pick up on what Dr. Prasanna Kumar said, that it's a low-hanging fruit. But the low-hanging fruit also depends on how tall the tree is. So how would you rate the tree and the fruit in this case?
We've been India's National Action Plan, and I'll just sort of give you an example. India's National Action Plan on AMR does mention the use of vaccines. Unfortunately, the engagement of the immunization division in the Ministry of Health is not there. So although theoretically vaccines can have a huge impact in preventing AMR, it seems like a low-hanging fruit with a lot of collateral benefits in reducing infections, reducing suffering. There's a lot of hesitancy, and despite the impact of the benefits of public-private partnership, looking at the use of vaccines in public health, there's a lot of wariness of the government in terms of using vaccines to prevent AMR, and this is something from the AMR program perspective. So a lot of challenges are there. So although it does seem like a low-hanging fruit, there are a number of challenges there as well.
Okay, the next question comes from Divya Balasubramanian, an MPH student, and the question is, in fact, there are two questions linked. What is lacking in the community to prevent AMR, and what areas can we focus on research at the community level?
Now, are we talking about vaccines? But I think the question is much broader. And if we're looking at prevention of AMR in the community, the basics are sanitation and hygiene, ensuring safe drinking water supply, ensuring hand hygiene in the community. Those are some of the key things which are important. But if we look at specifically with the vaccine lens as well in the community, despite vaccines being available in the immunization program, if we look at the coverage rates, they are not 100%. There are still some gaps. And again, there's a lot of work which needs to be done, because there is the anti-vaccine lobby as well. Thankfully, it's not as strong in India as in some of the other countries. But again, the community awareness is also a key thing in terms of understanding the mechanisms of AMR, but also the mechanisms how vaccines can prevent infections and thereby AMR.
Now, Professor Priscilla Rupal, you have your hand up. Please go ahead.
Yes. Thank you, Dr. Rajiv Dasgupta and Dr. Anuj, for that wonderful talk. I think the major issues that we're facing is that we are not quite sure of the burden in the community. we don't know what is the AMR burden in the community. And so when we introduce something which we perceive as a low-hanging fruit, we cannot really show whether we made a difference because we won't really know unless we have a clear-cut idea of the burden. So I just wondered, I know WHO has put a lot of thought into what should be done at various country levels. But is there some thought into the methodology of how to accurately assess burden? I know GLASS is doing some work with regard to that, but is there some move with regard to accurately assessing burden in the community level? Dr. Anuj, if you have any insights on that.
WHO has a methodology to estimate the AMR prevalence in countries or subnational levels as well through the AMR prevalence surveys. This is similar to the TB prevalence surveys. They are quite intensive, both in terms of the activities as well as the cost, but they can very easily, provide accurate burden of AMR in the community. And currently, they are being piloted in a number of countries. We're trying to push for this in India as well, and we are still sort of working with the government on this thing. But again, if we look at the specific example of India has a huge burden of typhoid. And for this, towards this, the WHO country office is working closely with the immunization division to look at the burden of typhoid, surveillance of typhoid in a targeted way in the community, prospectively, especially in peri-urban areas in 3 or 4 centers across India. And hopefully this will help studies to look at and monitor the impact of the introduction of the typhoid vaccines in these areas so that we have not only the prevalence of AMR, prevalence of typhoid in the community, including AMR, drug-resistant typhoid, but also the impact of the vaccine when it is subsequently introduced in these centers. So this is work in progress, and hopefully this will provide some answers to the prevalence of typhoid and the impact of vaccines to prevent AMR in typhoid.
Okay, Dr. Sharma, as the audience warms up, so there are 2 questions, one from Dr. Sarda Devi. Why has the mumps vaccine been excluded from the UIP? And a second one from Dr. Ravichandran, particularly in the rural context. How do we try to shift the focus of the population from curative to preventive aspects? Over to you, Dr. Anuj.
I think I'll take the second question first, and I will come back to the first one later. I mean, there's a lot of healthcare, private sector has a huge role to play, and the national health policy strongly identifies the role of the private sector, not just for AMR, but for all other areas as well. And preventive aspects are extremely important. And for this, you need political will, because health is still not a priority in India, as it is in a number of other countries. And that can come, and despite the UN General Assembly resolutions, the World Health Assembly resolutions, where the health ministers have strongly endorsed the Global Action Plan and have developed national action plans on AMR, percolation of these impact at the ground level is still a lot of things need to be done. And for this, we need the political will, especially in LMICs where health is still not prioritized. And for the preventive aspects, health promotion is an extremely important aspect. And again, this needs the political will. And in India, if we're looking at the health sector, health is a state subject, but so are the other sectors which are important for AMR containment, which include animal health, agriculture, and the environment. Food is on the concurrent list. So all of them need the role of the state governments for AMR containment and for engagement of private sector and shifting the focus to prevention. The preventive aspects needs the commitment of the state governments. Some of the state governments like Kerala and also Delhi have focused on, Kerala is doing a wonderful job in educating the people, the masses, about antimicrobial resistance. Preventing AMR is something that they're looking at through simple do's and don'ts, educating the people on what to do, what not to do to prevent antimicrobial resistance. So this is something which is extremely important. And for the first question from Dr. Sharda, whose was the previous focal point, the convener of the CARSAP group in Kerala, about the mumps vaccine. I would request Dr. Anuj, I think, who's the chair of the National Technical Advisory Group, who would be able to shed more information on why mumps vaccine has been excluded from the universal immunization program.
Professor Anuj,
first of all, I'm not the chair of National Technical Advisory Group. I'm just a member. But I was not there when that decision was taken. That has been taken a long time back. I think it was mainly cost issues, cost effectiveness, and knowing the burden of the disease. And that is what drives our, cost effectiveness, cost benefit ratio. All these things are taken in account, and the number of doses that we can produce, and there are a lot of other things for mumps. And I think the cost becomes much higher with mumps. I think that was one issue. And maybe the burden was not so well known at that time, but that is my reading why it was not done. But I was not a part of that decision. It has been taken, that is a long time back. But I think all these things are taken in a very, looking at many points when we are taking this decision of which vaccine to be introduced. Depends on the whether it is being produced within the country also. What is the cost of it? What is the disease burden? Very often the disease burden is the challenge in our country. And we cannot take a decision just offhandedly because other countries are having it. So I think these are the main things when we are doing it. And of course, there are many vaccines which can be used now, and government is trying to push. But when you put it in a national program, there is a lot of challenges in terms of giving the doses, producing the doses, because manufacturing, we have to have, enough manufacturers to produce such that the population is so huge that we really need to have there is no other country which has this much population which is giving this many doses. The operational things are also there. So very often these are given in a phased manner. For example, when we started HIB, pentavalent, it was started in few states and then it is spread to the other countries. Same happened with pneumococcus. Now we are having PCV. Polio, we started with IPV, then we increased the doses, fractional doses, because of the availability issues. Then you have now 3 doses of fractional IPV, because earlier we were having 2 doses. So things are lots of considerations go into this. But I'm not in a position to talk about all of them. Yeah. But I'm just a chairperson of AFI committee, not a chair, because chair is health secretary actually of ANTAC. None of us can be the chair of that. Thank you.
Dr. Anuj Sharma, to sort of reframe what Professor Anuj just said and brought her attention to. So as part of the AMR leadership, now when you look at it what she said is what we encounter daily as part of the immunization leadership or immunization decision making. But you representing the AMR leadership or AMR leadership in general, what do you think is the roadmap from the development to deployment journey?
First of all, Dr. Rajiv, I'm not representing the AMR leadership. I'm a technical, I would say, a foot soldier, supporting the national efforts, the national government, the national AMR program, and working closely with a number of AMR stakeholders within the country, both at the national level as well as at the state level. We also work with civil society organizations, and we have sort of focus on, not just the preventive aspects. Again, our focus is on all aspects of AMR. The National Action Plan. I had shown the 5 pillars of the Global Action Plan. India's National Action Plan is very closely aligned to the Global Action Plan. In addition, it has a 6th pillar on collaborations, coordination, and governance, looking at international collaborations, national level collaborations amongst the disease control programs, and the state level collaborations or the state action plans. Now, pushing for this, and again, the preventive aspects of this is a huge challenge, because one of the things, it's been an uphill task, and AMR is something which is still not very well understood by a number of people. It's only the technical stakeholders who understand it, but most of the technical stakeholders also look at AMR from their perspective. It's like the elephant in the room, where the microbiologists will look at antimicrobial resistance from the lab perspective. Pharmacologists would look at AMR from the antimicrobial consumption and use perspective. Clinicians will look at AMR from their patient's perspective and their issues in the side effects of medicines, etc. Public health people or the program people would look at it from the monitoring and the evaluation and the impact perspective. Getting everyone to join hands and look at AMR in its entirety is a huge challenge for most of us. And this is where, a lot of times when a new priority comes in, I mean, AMR is not a new priority. It's been a WHO priority since 1980s. There have been World Health Assembly resolutions. There was a global strategy in 2001. 2011, there was the World Health Day. Every time a new pandemic came, AMR was pushed onto the back burner. And Global Action Plan 2016, it came out, but again, the COVID pushed it again into the background. But again, we are trying to focus on this public health challenge, which is a WHO priority, not just within the organization, but also as a part of the quadripartite, working closely with FAO, World Organization for Animal Health, and the UN Environment Program to look at AMR from the One Health perspective, because WHO recognized this as one of the top 10 public health threats in 2019 and one of the 13 emergent health challenges for the decade. So this has a huge potential impact. It cuts across the SDGs and has a huge potential. But again, addressing it is a big challenge, as we've seen. A lot of good things are being done in India and a number of other countries. But again, a lot more still needs to be done.
As we draw to a close, possibly the last question from Dr. Priscilla about adult vaccination as a neglected area in most countries, and is there a special push by the WHO? And when we see this question in the context that we are actually at the midpoint of Immunization Agenda 2030 now, so what would your views be?
Even if you look at this document, the WHO document, which estimates the impact of vaccines in reducing antimicrobial resistance and antimicrobial use, it looks at both the vaccine use in children and in the elderly. And especially, because they are a special group, and there is a strong focus on that as well. But again, if you look at the maximum impact, it's the childhood vaccines which have been driving the immunization agenda. But of course, the adult vaccination is an area which is being also being identified as a priority.
So a quick probe. You categorize in terms of vaccines that are already available in early development, in clinical development and early development, etc. So are those, as a group, would they be addressing childhood needs more or adult needs more? And how do we see the relative advantages from the AMR lens?
It's a mix of both, actually. Primarily, it looks at two target groups. One is the childhood and the vaccines in adolescents. For example, if you look at the TB vaccines, it looks at vaccination in children as well as in adolescents, 10 years or older. And that is where a huge impact has been estimated. Now, the primary role of this document is primarily as an advocacy tool to push for immunization. If you look at the currently available vaccines, the impact of those vaccines is limited. Only if you club it with the vaccines in late stage and in early stages, you actually have the bigger impact. So hopefully we'll have identification that vaccines have a role to play and they need to be introduced. But again, a lot of this is also dictated by the costs and the burden. And a lot of LMICs, as Dr. Raneja mentioned, estimating the burden of AMR or the disease per se is a huge challenge. So which actually brings us to the question of stronger surveillance systems, stronger diagnostic systems, stronger surveillance systems, so that the laboratories which are able to detect AMR or even the diseases, that data is collected, collated, analyzed, and also not just the laboratory data, but also the epidemiological data, its linkages with morbidity, mortality, etc. Those are the things which need to be looked at in more detail.
Dr. Anuj Sharma, as always, an absolute pleasure to have this conversation. And as we draw to a close, I hand it back to Dr. Prasanna Kumar, Dr. Priscilla. Thank you very much on behalf of the audience.
Thank you.
Thank you.
Thank you for the wonderful panelists today, especially the speaker, Dr. Anuj, and also the other panelists, Dr. Rajdeep and Dr. Dhaneja, that we have heard from the horse mouth what's happening inside technical groups, how policies are being formulated, and how everything is being carried forward. Thank you, sir, for the wonderful insights from each of the panelists today. We are extremely thankful for your insights, and we are also thankful for all the participants who patiently listened till the end. Thank you all, and we are happy to continue this webinars, and we will post with a new webinar in the next coming month with the new panel members. Thank you all.
Thank you, everyone. It's wonderful to meet you.
Thank you.